Hey guys, this is Nurse Bauer, raising a shout out to Halsey for opening our tour of the basics, fluid and electrolytes. She may be bad at love, but we can prove we are still learning. Stay tuned for the basics. Alright guys, objectives. Let's take a look at these. Discuss variables that affect fluid and electrolytes. We're going to maintain fluid and electrolytes. We're going to identify appropriate assessment and nursing interventions to promote fluid and electrolyte balance. Describe the different types of interventions and solutions. We're going to discuss nursing interventions for intravenous fluid therapy administration and management. So our first contestant is fluid. What is fluid? Water. Substances dissolved. Substances suspended. Characteristics. Volume. Amount. Degree of concentration. Osmolality, concentration of substance and particles. So let's go back to substances dissolved. So that would mean, like, if you're looking at a sodium chloride, that it's clear. So that's something that you might want to take in consideration. Substances suspended, I kind of think of that as actually as blood. So for example, you can't see through blood, but you can see through a sodium chloride bag. It's clear, it's dissolved. Some of the substances might be dissolved in blood, but it's made up of other particles that are suspended. See the difference? Okay. Electrolytes is our second contender. Charged particles when placed in water. Notice the hand coming out of the water. Well, we have the lightning bolt. They all have precedence. So potassium is represented by a K+. Sodium is an Na+. Calcium, Ca++, two pluses. Remember, I'm extra special. Chloride is a negative. Ooh, gotta remember that. Sodium chloride. Oh, what does that mean? A plus and a minus equals an isotonic. Cool, right? Magnesium, Mg++. Bicarbonate, HC03. So the biggest part of fluid and electrolytes is balance. Fluid and electrolyte intake and absorption, fluid and electrolyte distribution, fluid and electrolyte output. So intake and output, that's why we did elimination first. That's why I needed you guys to read that stuff on elimination. Balance is dynamic interplay between these three processes. Okay, so fluid and electrolyte output is definitely made up of what you're taking in. So for example, if you're going out to exercise and you're not taking enough salt in, what's going to happen? You're going to have an output that's greater than your input. See how that works? Fluid and electrolyte distribution. Where do the fluids go? Where do the electrolytes go? And how they distribute through the body. Okay, fluid in, fluid out. Let's go. Water gain and water loss. Okay, so if you look at this chart for me, on the left, you're going to see your food and drink, your metabolism, your intake, your metabolism production. Okay, that's how much fluid you're gaining per day. Okay, so your insensible losses. So that means that you got to drink 2.2 liters a day. Do you see what I mean? To have the right output. Look. Skin, lungs, those are your insensible losses. Okay, that's what your skin is giving off and your lung is giving off when you're breathing and when you're just being. Next, you have your urine, 1.5 liters, and your feces, 0.1 liters. Okay, why is there less in the feces? I think we talked about that with elimination, right? Because your colon takes care of that. Now, if you have an ileostomy, okay, your body won't take care of that, and there will be more that is in your urine, or there might be less, there might be more in your feces. Do you see what I mean? Because your ostomy is going to not allow your colon to do its job. Okay, let's see what else. We have your output. So this is zero output if that's all you're taking in. Do you see how that works? Your body really uses a lot of water a day, doesn't it? So notice that 2.2 liters a day is equal to zero output. Okay, Normal output routes are insensible losses, feces and urine. Abnormal, vomiting, diarrhea, diuretics. So that's if someone's on Lasix or hydrochlorothiazide, bleeding, burns, gastric suction. Okay, so your body needs those juices in you so it can properly digest and use your body processes so that it can be excreted in the correct ways. So we have to be mindful of these abnormal routes because it will add up and you'll gain water or you'll lose water, and it's important to document those things. Next is body fluid distribution. So distribution is a process of moving fluid and electrolytes between various body fluids and compartments. Okay, so if you notice this little diagram that I have over here, it's pretty cool. Our total body, so this is for a male, and this particular one is good for a female as well, but 40% is solids, 60% is fluids, 2/3 of the interstitial fluid, so the ICF, the intracellular fluid, and then there's extracellular fluid underneath at 1/3. So the interstitial fluid is extracellular, and that's 75%, and then 25% is your plasma. So what's plasma in? Blood. Okay, so fluids are distributed in two distinct areas, and it says this right up here: intracellular and extracellular, ICF and ECF. Fluid compartments are separated by membranes that are freely permeable to water. All of these things are pretty basic, but definitely need to know. Intracellular is inside the cell, extracellular is outside the cell. Interstitial fluid is that fluid between cells. So that's like, for example, you get a cut, you peel open that skin, what's underneath? It's going to be wet. That's your interstitial fluid between the cells. Intravascular is fluid that's in the blood vessels. So that's important, right? So the difference between intracellular, intracellular, and intravascular, that's pretty different, right? Tissues versus veins. So take a look at this slide in relation to what you just saw. What goes in must come out. So liquids, solids, water oxidation, versus lungs, skin, and kidneys. What did you get? Dun, dun, dun. You got it. It's even. Other regulators of fluid balance include sodium, which promotes water retention, protein or albumin. It promotes body fluid retention. So those are important. So let's see here, promotes water retention. So when we have patients that are full of fluid, or you hear the doctor say, oh, they're full of fluid, or they have edema, we have to see what kind of edema that is and assess those types of things to see if maybe we need to have them on a lower sodium diet, or if sodium is something that they not watch. So that's definitely a nutritional piece that you'll need to take in. Protein or albumin promotes body fluid retention. So that has something to do with dehydration, right? If someone's not eating, let's say one of our older folks isn't eating, so that could be a contributor to the dehydration process, right? If your body's not able to keep the water that you put in because you're not getting enough protein, really might be helpful to increase their protein or make sure that they do eat. Lymphatics. Plasma protein shifts into the tissue spaces, cannot be reabsorbed into the vessels. So a lot of time you'll hear that, okay, well, the lymph system, so for example, you'll have someone with lymphedema with their ankle or their arm or their leg is swollen and it does not go down. It's because that protein shift that into that tissue space cannot be reabsorbed into the blood. So we have to push it back in through the lymph system somehow. A lot of times they'll use wraps and such to try to get that fluid back into place so that it doesn't do that spacing. Skin excretes approximately 300 to 500 milliliters of water a day. Whoa, we sweat a lot, right? If you think about it, our skin is our largest organ, so we're really going to have it use a lot of our resource, right? So a 300 to 500 milliliters per day, especially if you're sweating a little bit, is going to be a massive deal. Lungs. They excrete approximately 400 to 500 milliliters of water a day breathing. Whoa, so it costs me a total drink of water to even breathe all day. So you have to, this is the importance of breathing, the importance of water, importance of drinking, all those things, right? So when we say drink, we need to drink because look at it, just to breathe all day, you're doing 400 to 500 milliliters of O2 just as a necessity for breathing. Extracellular volume deficit. So we're just talking about that different type of fluid, extracellular. And that means insufficient isotonic fluid in extracellular compartment. Okay, so that means that's a deficit. So insufficient, deficit, isotonic fluid. So what's isotonic mean? That's the other thing we need to go over. So isotonic is a level that is the same as blood. Okay, so isotonic fluid is going to be the same as blood. So that's that positive and negative. Remember that? Okay, so that's isotonic fluid in the extracellular compartment. So that means vascular and interstitial. Okay, output of isotonic fluids exceeds intake of sodium containing fluid. Okay, so that means it exceeds intake of sodium containing fluids. That would be like sodium chloride. It exceeds the intake of that. So hypovolemic. So hypo means low, right? Volemic. What does that mean? Vol means volume. So hypovolume. Emia, right? Hypovolume, decreased vascular volume. So what can happen with vascular volume? So vascular volume can be blood, right? So vascular volume, think, I'm going to write on here for you. Think blood. Think, let me get a thicker highlighter. So vascular volume, think, oh, maybe I should write on it red for you. Think vascular volume, think your blood, and it's going low. Blood. We'll write it on here for you. Blood. Low. All right. So this one's the opposite. So this is volume excess. Too much isotonic fluid in the extracellular compartment. So again, isotonic, that positive and negative, that's the same as blood. We're not going any shifting. We're going to do vascular and interstitial. Intake of sodium containing isotonic fluid exceeds fluid output. So intake exceeds output. Okay? All right. The optimal balance. Fluid and electrolyte intake and absorption match the fluid and electrolyte output. Okay, so that means that if you're eating and drinking enough water, salt, potassium, any of your electrolytes, we're getting enough in, then we're outputting enough as well. We're not holding on to it. We're trying to actually get rid of the fluid, the same amount of fluid that we're putting in. Remember, we got to stay hydrated to show hydration, okay? Volume, osmolality. Okay, we were talking about that word earlier, osmolality and electrolyte concentrations, okay? So fluid and various body compartments are within normal ranges. So volume, osmolality, and electrolyte concentrations of fluid in the various body parts are within normal ranges. So that means that when you take a blood sample, for example, and the potassium is within that normal range, okay, we want it to be that normal range. Now, if it's out of normal range, then that means that there could be something else going on. That optimal balance is not there. sometimes we can also see that the optimal balance is there, but there's also a volume deficit. This might happen with bleeding. So me and Miss Ebert were sitting there the other day and she was like, so have you heard of little Maggie? Well, this is little Maggie. Little Maggie is 1.5 to 2.5 years old. That's your magnesium. She ate 3.5 to 5 bananas. That's your K. And drank 8.5 to 10.5 ounces of milk. That's your calcium. Then she took a 135 to 145 hour nap after swimming in the ocean. That's your sodium. This is a really cool way of trying to put it all together. Now we're going to have a little contest. I need you guys to bring in your little pictures to class if you can. Best drawing of little Maggie to see if we can help each other remember this one. Okay? So we were talking about some of these in the last couple slides. Isotonic. We kind of went over isotonic. The same as blood. Okay? Then we have hypotonic and hypertonic. So hypo means low. Hypo. Think oh, low. Hyper is like me. I'm a little hyper. So think hyper for high. High solutions. Do you see what that means? So if you look over here, I'm going to circle. We'll use blue. Okay. Hypotonic. Okay, this hypotonic, do you see how there's less particles here? And then the hypertonic, do you see how there's more of the particles there? But the isotonic, there's no change. So this is what it's supposed to be. This is what's out of the fluid inside the cell. See, this is in the cell. This is outside of the cell. It's the same. But this is what happens when there's more or less one other way. So we were talking a little bit about extracellular fluid. So sodium holds the water in the extracellular compartment. So remember that. Sodium holds the water in the extracellular compartment. So sodium's going to hold on and keep all the water. Isotonic solution has the same concentration as the extracellular fluid, okay? So concentration is the same unless osmolality is at an imbalance. So the osmolality imbalance, okay? We have changes in the degree of concentration. So the concentration of the solutes in the solution. So we got the water and then we got the things in the water, okay? Hypernatremia, so hyper fluids are too concentrated with that Na. We got too much positivity here. We got too much going on. Woohoo! Hyponatremia, we are low. Okay, fluids are too dilute of positivity. We need some sodium and it's not helping us. These can occur with or without extracellular volume imbalance. Okay, so this is the other thing too. Okay, so this can happen even if everything else is working right. So it might be that your medication that you're on or something like that might be causing this imbalance. Okay? Movement of water and electrolytes. Movement of water and electrolytes. Active transport requires energy. ATP moves electrolytes across the cell membrane against concentration gradient. Sodium/potassium pump. So if you think about it, think of this as your water pump. Okay, you need an activator. You have a security guard. Okay, and it requires a PT pass or your badge to get through the door. Okay, so that's your active transport. Diffusion. This is your passive movement. This is the one where there's no gatekeeper. It's just the revolving door that you can go in and out. And if it's too crowded, you can come back through to the outside or you can go back in depending on which way is too crowded. People like to even it out. So if you can think of it that way. Osmosis. Water moves through a membrane that separates fluid with different particle concentrations. So this is more of like a, can I get through this one? It's like those people that have that cool ability to go through doors. Was it like Jack? In The Incredibles, he can go through the door. Only certain people are allowed through. Passive movement of fluid of lower solute concentrations to higher solute concentrations. But this is the water. So the water moves through and it separates everyone else. Jack's kind of like water this time, okay? So if you can think about it, another way to think of this is a strainer, okay? So osmosis is kind of like a strainer. So if you take the noodles out and you're straining it to the water, that osmosis is moving from the different. I like to move it, move it. I like to move it, move it. I like to move it. All right, we got to move it, guys. Filtration. Fluid moves in and out of capillaries. Okay, what are capillaries? Think about it, those little tiny blood vessels. Net effect of 4 forces, okay? To move fluid out of capillaries and small venules, to move fluid back into them. Hydrostatic pressure, force of fluid. Okay, think hydrostatic. What does static mean? So hydro means water, right? Static is pressure. Okay. Osmotic pressure is the drawing power of water and depends on the number of molecules in solutions. So osmosis is discussed in detail in the next slide, so we're getting there. Hydrostatic pressure is the force of the fluid pressing towards the force of the surface. So in the process of filtration, hydrostatic pressure differences, they determine movement of the water. With the increased hydrostatic pressure on the venous side of the capillary bed, and edema will occur. So if there is pressure, hydrostatic, so a pressure on that venous side, it will cause edema. However, diffusion of the electrolytes across the cell membranes requires proteins, and those proteins are what serve as those channels. Those are those gatekeepers I was talking about. For example, when the sodium channel in a cell is opened, so the sodium opens, it diffuses passively, it goes ahead over because the concentration is lower. The other ions are tightly controlled, and it plays an important part in the muscle function. Blood colloid, osmotic pressure. Inward pulling force caused by the blood proteins that help move the fluid from the interstitial tissues back into the capillaries. This is important. Pressure. This is a nice illustration of pressure that shows the interstitial fluid, the capillaries, the albumin, all these things. This is pretty cool. Are you thirsty? Hey girl, are you thirsty? Open wide. Okay, because if you're thirsty, you need to drink up. So, rise in body temperature. The osmosis receptors in the brain sense that the body fluid is the osmolality is off. Increase in fluid osmolality, decrease in body fluid volume receptors sense the amount of fluid in the body. Help! And I'm thirsty. So thirst is important. It regulates the fluid intake. When plasma osmolality increases, the receptor-mediated thirst. So blood volume decreases and the baroreceptors mediate the thirst, and located in the hypothalamus is all of these things. So all of these receptors that say, hey, you know, maybe I'm thirsty, because your body's kind of like, it has a barometric responder. So it's like, oh wait, there's something wrong going on here, and I need to figure out what it is. I can help it with water. Dry oral mucous membranes is definitely something like, oh my gosh, my mouth is dry. Maybe you need to drink something. This is how some of this works. This is a nice wheel that shows you the increase of plasma osmolality, decrease, angiotensin 3, psychological factors, dry pharyngeal mucous membranes, and the angiotensin 2. So thirst mechanism is located within the hypothalamus of the brain. Osmoreceptors continually monitor plasma osmolarity when it increases. They cause thirst by stimulating neurons in the hypothalamus. Dry oral mucous membranes also cause thirst. People who are alert can obtain fluid or communicate with their thirst to others, and fluid intake restores the fluid balance. Infants or patients with neurological functions or psychosocial problems, sometimes older adults who are unable to communicate this or perceive this, are at risk for dehydration. Major hormones for regulation: ADH, aldosterone, and ANP peptide. ADH regulates osmolarity by regulating how much water is excreted in the urine. So if this regulator is broken, what's going to happen? It's going to hold, right? Or it's going to get too much. Released from the pituitary gland, circulates in the blood until it reaches the collecting ducts in the kidneys. So your blood and your kidneys are really interrelated. Tells renal cells how to reabsorb water, returning it to the blood. So if there's too little of ADH, what do you think is going to happen? Too little ADH, water reabsorption is not going to happen. So RAS, R-A-A-S, renin, angiotensin, aldosterone system. Regulates ECF by influencing how much sodium and water are excreted in the urine. Regulation of blood pressure. Special cells in the kidney release renin. Renin converts to angiotensinogen to angiotensin 1. Enzymes in the lungs convert to angiotensin 2. Angiotensin 2 causes vasoconstriction in some vascular beds. So this means that it increases blood pressure in those vascular beds. Okay, so aldosterone. Aldosterone causes reabsorption in sodium and water in isotonic proportion in distal renal tubes. So what does that mean? So it causes reabsorption of sodium and water. Okay, so sodium and water is going to absorb, which we're going to hold it, okay, in proportion to distal renal tubes. So that's where it does it. Sodium and water return to the blood, increasing the ECFs, which is extracellular fluid. So extracellular fluid is increased. Contributes to electrolyte and acid-base balance by increasing urine excretion of potassium and hydrogen ions. So it's increasing urine excretion of the potassium. So aldosterone equals increase of urine excretion of potassium and hydrogen ions. With decreased blood flow to the kidneys, more renin is released. So, with decreased blood flow to the kidneys, more renin is released. ANP. ANP. Influence how much sodium and water you are excreted in the urine. Cells in atria of the heart release ANP when stretched. So increased ECV. So when there's increased ECV, you're going to see a release of ANP. ANP inhibits ADH. Okay, so it's inhibiting ADH by increasing the loss of sodium and water. So inhibiting ADH equals increase in loss of sodium. Increase in loss. This is a lot of pluses and minuses, right? So let's go back to my pen. Let me grab it. So inhibits ADH. So down, right? Inhibits ADH by increasing the loss, decrease of sodium and water in the urine. So we're inhibiting ADH by increasing the loss of sodium and water. So I love this little this little cartoon, renal compensation, and shock. Okay, so increased ADH equals fluid retention. Okay, and then let me get my other pen here. So an increase in ADH equals fluid retention. Thou shalt not pee. Okay, and then aldosterone. So this is Big Al, if you see his name tag here. Big Al, aldosterone is equal to sodium and fluid retention. So he's holding on to the sodium and water. Okay, let me just, I was going to say water, but let's just make it blue. Okay, so we are holding on to the fluid and water, and the sodium and water, and then down here angiotensin equals vasoconstriction. So in an angiotensin 2, squeezing the blood pressure cuff, which is going up, making their blood pressure go up. So that's what your patient's going to look like. With a circle of thirst. Okay, so this is just a little wheel, I would say, of how plasma osmolality and circulation of fluid helps with thirst. And you can go ahead and look at that ADH secretion, thirst increase, water excretion, retention. Electrolyte imbalances. This is an interesting one, so I want you guys to be careful. I'm going to go ahead and get my pen out. So abnormal plasma concentrations. Abnormal plasma concentrations of electrolytes, and that's going to be your potassium, your calcium, and your magnesium. So plus, 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 right? And this is sodium, effective osmolality. Okay, so electrolyte concentrations measured from the blood samples, not from inside the cell. Remember that. So if you're hypo or hyper, remember those are the samples from the blood and not from inside the cell. So that's extracellular, right? So because it's outside the cell. Sodium and chloride. Sodium is a main extracellular fluid. So extracellular, okay, ECF helps govern normal ECF osmolality, helps maintain acid base, activates nerve and muscle cells. So activates nerve and muscle cells. So what might happen if you have too much? Okay, if it activates nerve and muscle cells, you might have hyperactive nerve and muscle cells. If there's too little, you might have less nerve and muscle activity. See how that works? Influences water distribution. So if it's out of whack, so is your water. Normal value is 136 to 145. Just know the values on these slides, know the values in your book. If they are different, you can go ahead and shoot me an email, but they should be relatively the same. Chloride is the main extracellular fluid, so it's in the extracellular again. Helps maintain normal ECF osmolality, affects the pH, okay? Plays important role in maintaining acid-base balance, normal value, right here. As you will see in this slide, if you look, serum chloride 95 to 110. On the last slide, it was, I think, 96 to 108 or something like that. That's okay. You're going to see that in every facility. Things are a little bit different. It's the way that their machines work, and what's normal there might be not normal in another place, but they're relatively the same. The salt of the mine, sodium and serum chloride. Okay, you can add a little chloride. It's a major extracellular ion. See how this works? This is really cool. Die harder battery. Sodium pump electrolyte charger. So, and see how sodium is the charger. I really like this this diagram. Hypernatremia. So I'm going to be hyper, water deficit, hypernatronic condition. Okay, hypertonic. So what do we mean by hypertonic? If I remember correctly, hyper Man, we had a lot of solutes, right? There was a lot of them. Hyper, it was everywhere, all kinds of solutes, There were a lot of them. Okay, so two general causes of hypertonic. So hypertonic, two general causes were loss of more water than salt. Okay, so loss of more water than salt. Okay, so salt is fine. Okay, water loss is increased. See how these up and downs are kind of crazy? But once you understand them, you'll know them. Gain of more salt than water. So Na, okay, is up. H2O is down. Sorry, I don't have a better mouse. Interstitial fluid become hypertonic. So interstitial, what's interstitial mean? Okay. Water leaves the cells and shrivel. So cells shrivel with hypernatremia. So cells think, hi, we're gonna shrivel, like shrill, okay, shrivel, okay. So that might help. Interstitial fluid, that I think that'll be a good diagnosis. You guys will hear that, okay? Okay, so this is hyponatremia. Hypo, which means low, right? Hypotonic condition, which means there's low stuff. There's less stuff in your solution. So two general causes, gain of more water than salt. So gain is high, okay? We're going to do high of more water than salt. So we're going to think of the ocean. We still have more water than salt, or we would have thick type water, right? It would kind of be crusty. Loss of more salt than water. So loss of more salt than water. So Na is lower than H2O. Dilute condition causes the water to enter cells, causing them to swell. So this guy is really, really happy and bloated. Okay, we're gonna swell. We're gonna do our little hands like, and maybe a little foot. What do you think? Remember our swollen little guy instead of our shriveled one from last time. So hypo, we're not gonna be shriveled, we're gonna be swollen. But hyper, we're gonna be shriveled. Okay? Clinical dehydration. This is a picture of what's going on inside your patient's body when we say they're clinically dehydrated. Extracellular fluid, so that's fluid outside of the cell, is volume deficit. So the fluid outside of the cell, there's not enough of it, and they are hypernatremic. So hypernatremia, there's too much positivity around here. Okay, so there's too much of the solute, right? So there's too much salt. EVC is too low. So the volume is too low and the body fluids are too concentrated. So we don't have enough water and we have enough of the electrolytes, but it's just because we don't have enough water, we don't have enough of it looks like there's too much of the concentrate. So there's more concentrated solutes because there's not enough water. Does that make sense? Body fluids have increased volume and are hypertonic. So body fluids have decreased volume. So there's low volume. So there's not enough stuff in there. So there's low volume, and they are hypertonic. So that means the same thing, right? Hypertonic. So it could be both. The basics of hydration. I really like this little slide. No pun intended. Watch us go up with too little body fluid. So if you're looking here, it says this way to the fluid volume deficit dehydration. Watch us go down with too much bodily fluid. So your specific gravity, your HCT, and your sodium are going up. Watch us go up with too little bodily fluid, and then watch us come down with too much. So too much fluid, it's going to go down, down, down. Basics of hydration using your HGB and your HCT as a guide for hydration status. So it's showing you this right here. So your hemodilution, there's your plasma, and there's your, here, this is your plasma, and then here's your solutes. So here's your solutes here, and this is normal. Okay, so that's normal plasma, and then there's your red blood cells, and then your plasma. So that's your hypertonic. Okay, which is it? What occurs when water is shifted across the cell membranes? Okay, what process was this when the water is shifted across the cell membranes? I'll give you 3, 2, 1. Osmolality imbalance. So that's when an osmolality imbalance occurs when the water is shifted across the cell membranes. All right, which one is it? Oh, I gave you the answer. Extreme thirst, dry, flushed skin, fever, confusion, agitation. So this one says it's hypernatremia. So what do we know about sodium that's going to cause those things? Extreme thirst. Okay, so having hyper, so there's too much sodium. So what's that going to cause? It's going to cause us to dry out, right? So dry, flushed skin. Yeah, it's going to be dry because it's going to pull it from everywhere else. Okay, so we have too much of that sodium. Fever. Well, we have all of those receptors in there that's telling us that something's going on. And if we are dehydrated, we are going to be a little more dry. We're not going to cool properly, so because our skin uses all of that stuff, so it's going to be feverish. Okay, we'll get that. Confusion. Confusion? Why confuse? Oh, yes, that's right, because sodium helps with nerve and muscle functions. It excites it. So it excites nerve and muscle function. So I mean, our brain is full of nerves, full of nerves. So confusion, yeah, that could definitely happen because everything's not firing properly. Agitation. If I was extremely thirsty, dry, feverish, and confused, I might be agitated. I might be agitated. So next, let's see here. Yeah, that's our lab value. We definitely needed to see that. Seizures. Wait a second. Why would seizures happen? What is a seizure? Oh, wait. Yes, let's go back. Hypernatremia, there's too much of it. Okay, so it's also causing too much excitement on those nerves. It's firing too fast. It's something, now I'm hot. Okay, so with a fever and firing too fast and my brain is overloaded, thank you, fever threshold is seizure. Okay, we got a seizure threshold and we have hit it with hypernatremia. I hope that one helped. Okay, so let's take a look at this one. Sudden weight gain. Okay, so we're going to think through these. Dependent edema, crackles. Full neck vein when upright. Ooh. Decreased hematocrit. Okay, well that's our lab value. So decreased hematocrit goes to something I think we know. But let's look at sudden weight gain. Okay, so what's that mean about fluid? So sudden weight gain means that we are somehow holding on to the fluid, but I don't know where yet. I don't know if it's extracellular or if it's intracellular. Are my tissues holding on to it or are my veins? I don't know yet. So dependent edema. Dependent. What's dependent edema mean? We might have to look into that, right? Crackles. Ooh, 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 it's in the lungs. Ooh, ooh. Okay, crackles means grumblies in my lungs. Okay, so that gives me another. Oh, full neck veins when I sit up. It's in the veins. Okay, it's in the veins. So what does that mean? Extracellular. Okay, so decreased hematocrit. Extracellular volume excess. Yes, it was that easy. Oh man. Number 4. Which is it? Nausea and vomiting, headaches, apprehension, decreased level of consciousness. Ew. None of these sound very good, right? Nausea and vomiting. Oh, wait, that's an abnormal way to get rid of something, right? Okay, so headaches. All right, well, if volume is low or something, maybe I might get a headache, right? Like if I'm dehydrated, I get a headache, right? That's what happened last time. Apprehension. Wait a second. Apprehension. Something's maybe not firing, right? Decreased level of consciousness. Oh, wait. What happened with that sodium stuff again? Okay, so the sodium is low. Okay, so we have our lab value here. The sodium is low. So that means that the positivity is not there. It's low because there's nothing there. Okay, so everything's going to be the not excited. Okay, so it's not excited to see me. It's not excited at all. It's a sad little man. We're going to put our sad face here. He's a little slow and tired, and he's not having a very good day, and he's nausea, and he's vomiting. We're going to put his vomit there. So what is he? Let's see here if I can go ahead and see what. Hyponatremia, you were right. Number 5. Okay, which is it? I'm going to stop playing with this thing so it can actually give me the right answers. Sudden weight loss, tachycardia, neck veins flat. Wait, that was different than the last time. And wait, sudden weight loss. Loss. They're not holding on to fluid, right? Tachycardia. Woo! Maybe there's something going on in there. Tachycardia, what will cause that? Fluid excess or not? I guess it's trying to keep pumping stuff, right? So oliguric, oliguria, olig, sometimes urea, so sometimes peas. Okay, so dry mucous membranes, hypotension, which kind of goes along with tachycardia, right? If the heart's pumping super fast, it doesn't get a good pump in, okay? Inelastic skin turgor. So skin turgor isn't bouncing back, it's kind of slow. So what do you think this is? Extracellular fluid volume deficit. It was that easy. You guys got it. Okay, this is number 6. Tachycardia, hypotension, dark, yellow, urine, dry mucous membranes, dry flushed skin, postural hypotension. Hypotension, postural means sitting, standing perhaps. Hypotension. Tension. Serum osmolality of less than 295. Okay, so tachycardia, that means we learned from last time that it's low. Okay, so there's a volume thing maybe that's making a hypotension. That's also usually a volume thing. Okay, dark yellow urine. Ooh, something's not concentrating right. We're getting rid of stuff, but there's not enough water, right? Dry mucous membranes, yeah, we talked about that thirsty stuff. Dry flushed skin, same thing. Just sounds dry. Sounds like a desert. Postural hypotension. So when I sit up, something gets lower. Well, that's still not good. Okay, so I wonder what she is. Clinical dehydration. Totally sounds like some of my old people that come in who are dehydrated. We really have to watch out for these people because this hypotension, tachycardia, remember we talked about that albumin levels? Okay, so their albumin levels may be low and they're not able to hold on to that fluid and they're not able to have that volume with fluid. Okay, so those are things that we really want to watch out for, especially in our older population. This is just a cool little meme for you. So electrolytes charge your calcium, potassium, magnesium, and sodium are all pluses, and your negatives are your bicarb, your chloride, and your phosphorus. And if you notice, these a lot of times balance out each other. You see potassium chloride a lot. Calcium definitely teeter-totters with phosphorus. Bicarb is a negative and keeps everything else in check. It's a pretty cool system. This chart is just an FYI. No, I'm not going to say that you need to know all of this. However, it's pretty cool. Your saliva, it'll show you what's in there and how acidic and stuff it is. It's pretty cool. So if you notice our cerebral spinal fluid, it's pretty salty. So when people say you're salty, I guess we can say it's in my brain. But these look pretty cool. We have bile. If you notice, bile has one of the highest salt factors in there as well. So this is a pretty cool chart. Okay, these are potassium fun facts. Potassium, total body potassium is 4,000 milliequivalents, not milligrams. Okay, milliequivalents. Daily dietary intake of potassium is 40 to 150 milliequivalents. Let me get my little marker out here again, and let's just do milliequivalents per day. On an average, 1.5 milliequivalents per kilogram of body weight. Okay, this is going to be important when you do dosage calculations. The intracellular, so that means it's in the cell, concentration of K plus, which is the potassium meme, 150 to 160 milliequivalents, okay? So, and since she has red here, I'm going to pull out the red. And the extracellular, what does that mean? Blood draws, okay? Extracellular means blood draws, okay, concentration is going to be 3.5 to 5 milliequivalents. So that means that the cells are hogging it, right? So most of it should be in the cells and not in your blood, not in your extracellular fluid. So this is where they get that blood draw. This is your potassium needs to know. You need to know. Main intracellular fluid action. So this is your cation cation. Okay, so regulates cell excitability. So you saw that on your last slide though. So most of it is intracellular. It's in the cell, okay, and then only a little bit is outside of the cell in comparison. Regulates cell excitability. So it does the same thing. So permeates the cell, affects the cell's electrical status, helps control ICF osmolality and ICF oncotic pressure. Okay, so it's found a lot of things. It's found in fruits, potatoes, molasses, Brazil nuts, and bananas. We know it mostly in bananas, but I think especially potatoes, we don't think about. Brazil nuts, I mean molasses, we don't really think of those types of things. Potassium is also found in a lot of preserved foods, so you'll definitely see that if there's a preserve food like dried fruits and stuff, you'll definitely see an increase in potassium. I love this little cartoon. More or less can be life-threatening. Okay, potassium is a very, very, very special electrolyte, and it can cause all kinds of things. Warnings to watch: potassium levels in patients with renal failure. They are not excreting potassium levels. They're not excreting their potassium properly. So we have to really be careful with them. Hydration imbalances: people with dehydration problems might have increased potassium levels because of those fluctuating osmolality problems. Cellular damage: burns, accidents, because they're getting rid of their fluids in unconventional ways or abnormal ways. Diabetes: the sugar is hogging up the site, so it seems like it's too crowded. Remember I told you that your electrolytes are going to go where it feels more comfortable? Well, if it's full of sugar, then the potassium might not want to stay. Or the potassium might want to stay and kick sugar out. Watch the K levels with the digitalis, diuretics, and IV fluids. So increased K causes irritability, diarrhea, nausea, irritability. That's interesting. And dysrhythmias. So it increases, so it excites, so it causes dysrhythmias if it's high. Ooh, I can see how that works, right? Potassium at 6.5 or 2.5 can be life-threatening. The safest place is between the two, so it can cause these things both sides. So magnesium is another special cat. Leading ICF cation, low in ECF, also in the bones. That's pretty cool, right? That we think of magnesium for in the bones. Contributes to enzymatic and metabolic processes. So protein synthesis, so it helps synthesize your proteins, okay, which modifies nerve impulse transmission. So if your magnesium is up or down, your nerve impulse transmission may be up or down, and the skeletal muscle response. So your muscle response is going to be in relation to your magnesium levels. This is really important in pregnancy because what is the uterus? The uterus is a large muscle, right? So therefore, when there is a problem, so we give magnesium, okay, to stop certain processes. So, and it's because it's a skeletal muscle response. Okay, so found in dark leafy green vegetables, whole grains, and magnesium-containing laxatives. Phosphorus is a main anion, so low in ECF, okay, so low in extracellular fluid and main in intracellular fluid, so it's in the cell and not a lot in the extracellular. Also in bones, again, promotes energy storage. Ooh, that's interesting. Promotes energy storage and carbohydrate, protein, and fat metabolism. So acts as a hydrogen buffer found in milk and processed foods. Interesting. Processed foods, energy storage. That might have something with carbohydrate metabolism, because our body likes to store carbohydrates, right, for energy. So that might be something that when we're watching diets and talking with patients and clients about, milks and processed foods. Processed foods are all kinds of foods, right? Like cheeses and stuff even. It's promoting energy storage. So it might be promoting, the carbohydrate, protein, and fat metabolism, but it also stores. Normal value is 3 to 4.5. Calcium is my special cat. So major cation in teeth and bones, found in equal concentrations in ICF and ECF. Oh, so that's different. So it's equal. So if it's interstitial and extra, so it needs to be a balance, right? Found in cell membranes and helps us cells stick together and maintain shape. So it helps everything maintain its shape, acts as an enzyme activator within muscles. So if your calcium is low, your activation would be low, right? Aids in coagulation, so that means your coagulation, so your sticking of the things together, right? Affects cell membrane permeability and firing level. So, and firing level, that's interesting. Found in dairy, broccoli, oranges, and need vitamin D for best absorption. Your calcium and phosphorus relationships, you can see the serum calcium is supposed to be between 9 and 11, and your phosphate is 3 to 4.5. Go buy your books, please, for those, or your handout for those lab values. But this is your relationship between calcium and phosphorus. Calcium goes up and phosphorus goes down, or when your calcium goes down, your phosphorus will go up. This is definitely a relationship that we need to be careful of, because patients with high calcium are usually going to have a low phosphorus, which is going to upset their muscle and potentially brain functions. Bicarbonate. We're not going to dive too deep into bicarbonate. It presents itself in the ECF, regulates the acid-base balance. We're going to get more into that when we get into oxygenation and when you get into your med-surg classes. However, it regulates the acid-base balance and is especially important in respiratory failure and other critically ill patients. You'll see a lot of bicarbonate being used, especially if you come over with me to Highsmith. You'll see bicarb, especially in patients that are really critically ill. IV solutions. So this is where we're going to put it all together. Your crystalloids are your isotonic, hypotonic, and hypertonic solutions. Okay, so isotonic is dextrose 5, D5W, and 0.9 normal saline, which is sodium chloride. Okay, so what are we going to look at for that? So hypotonic, so low hypo, is 0.45 normal saline. So that's half normal saline, right? So that would be a hypotonic solution. So more water than sodium. Hypertonic is dextrose, which is 5% and 0.45. So that's hyper. That's a lot of stuff in there, right? There's water in there, but there's a lot of other sticky stuff in there, right? So, and then 3% sodium chloride. Woo, that's a lot of sodium. That's a lot of salt and chloride, right? Dextrose 10, again, is a lot. There's a lot of sugar in there. Okay, there's a lot. So those hypertonic. Colloids are hypertonic, so more concentrated. So that's albumin. Okay, so we were talking about albumin and plasma protein fraction, dextran, and hetastarch. So those are things that are hypertonic. What types of things might that help? That might blood volume, right? That volume might help treat those things like the tachycardia that you see from those patients. I love this top 5 fluids. Top 5 fluids, normal saline. I'm used to expand volume, dilute medications, and to keep the vein open. That's cool. All right, lactated ringers. These are your different solutions. So I am commonly used for fluid resuscitation. Ooh, that's cool. These fluids are isotonic, same osmolarity as body fluids. Okay? Next, let's try hypotonic. I'm kind of tricky. I'm isotonic until inside the body, and then I metabolize glucose and become hypotonic. So isotonic until I'm in the body and I become hypotonic. Okay, so I'm used for hypertonic, so I'm used for sodium and volume replacement. Caution, go slow, monitor my blood pressure, pulse rate, and quality of lung sounds as serum Na and as well as serum Na and urine output. So you want to look at all of those things when you're giving D5 half normal saline. Okay, oh my, don't give D5 water to infants or head injury patients. It may cause cerebral edema. That's pretty cool too, right? Need to know. IV therapy imbalance. Please be aware of what's going on with your patient. Always look at your patient first. I want you to look at your patient first. Vital signs, vital signs, vital signs. We have to do safety first, okay? Because even if someone reports that something, let's say the blood pressure is 180 over 150, okay, you have to go in and retake that blood pressure just to make sure that the cuff wasn't broken, that they put it in the wrong place, that the patient was squeezing on something. You have to assess your patient first. Take note of the type of IV solution infusing, okay? Look at it, because guess what? That nurse might have messed up. Okay, I've had it happen several times where I walk in there and the IV solution was supposed to be half normal saline and it was normal saline. Ah! Big difference, right? Correlate the patient's condition with the type of IV solution, okay? If you're high and dry, we've got to treat it appropriately. Any concerns, you have to notify the physician. Okay, so this is kind of the cool part, nursing process and assessment. What you can do is we're going to start with the nursing history, age, the very young and the very old are at risk. So the environment, is it excessively hot outside or is it cold? Wintertime, especially up north, when you get the really cool or under the 20s degrees, your body their processes shut down and you can get dehydrated without having your cues. Dietary intake, fluids, salt, foods rich in potassium and calcium and magnesium. We really have to have a balanced diet. It's not just a saying. We really do need a balance to our diets. Lifestyle, alcohol intake and history. Alcohol reroutes processes and make things different and difficult for digestion and for your liver to work. So there's a lot of interesting things that alcohol does, so that we have to make sure that the patient is not or getting most of their calories from alcohol, because then they're probably not getting the proteins that they need as well to have a healthy lifestyle. Medications include over-the-counter medications, herbals. Green tea is a huge one. Green tea is a blood thinner. We kind of need to know when people are taking something or drinking something every day. It might not seem like it's harmful, but we need to know so that if that patient goes for a surgery or something, we know what's going on. Medical history, recent surgeries, physiological stress, all has something to do with your diagnoses, especially with dehydration and what you're doing. Diuretics, that green tea is also a diuretic, it'll make you pee. So those might be causing your electrolytes to go up and down. Acute illness or trauma, respiratory disorders, burns, trauma, all will pay a big price for your fluids. Let's see here, chronic illnesses, cancer, heart failure, oliguric renal disease. It messes up all of your functions with your fluid and electrolytes. Cancer has a tendency to put the fluid where it doesn't need to be. Heart failure does the same thing. Your renal disease, everything that has to do with fluid is in your renal. Who's at higher risk? We definitely need to keep in mind our infants. They do not have matured kidneys yet. Immatured kidneys cannot concentrate urine or reabsorb electrolytes appropriately. The elderly have kidney function problems with fewer functioning nephrons. This cannot concentrate urine and reabsorb electrolytes properly. We have a new trend, or it's not really new any longer, but our gastric sleeve and gastric absorption people. So let's see, like our gastric bypass people definitely have a problem reabsorbing their electrolytes because their stomach and their intestines are now different. So a lot of them end up taking liquid vitamins to help with absorption of their electrolytes. Decreased glomerular filtration rate, diminished ability to concentrate urine. So anything having to do with kidneys is definitely a higher risk. Physical assessment. We're going to look at their daily weights. This is a simple, easy thing that we can do every day to kind of see where they're at. Indicator of a fluid status. Use same conditions. So it's going to see, by a daily weight, we're going to see if they've gained 3 to 5 pounds overnight or 1 to 2 pounds, and it'll definitely have a difference. Fluid intake, 24-hour in and out. This is something that we can do to ensure that, hey, they are taking in enough, or they're really not. Intake includes all liquids eaten, drunk, or received IV. Output is urine, diarrhea, vomitus, your gastric suction, Wound drainage, that's a big one. Wound drainage does count because that is output. It's outside of the body. It's coming out. So we have to. Nursing diagnosis. So some of these are really cool. So decreased in cardiac output, acute confusion, impaired gas exchange, impaired oral mucosal membrane, risk for electrolyte imbalance, ineffective tissue perfusion, impaired skin integrity, deficient fluid volume, excess fluid volume, risk for injury. Risk for injury, I wonder why. Oh yeah, because those, especially the sodium and calcium receptors and potassium, they could really, they help with the muscle activity, right? So that excitability or not, so if it's high or low. Deficient knowledge regarding disease management. Teamwork makes the dream work. Planning, goals and outcomes, setting priorities, collaborative care. We have to come up with goals and outcomes that these patients will actually adhere to. Set their priorities, what we want to work on first. Okay, maybe it's just eating better, or maybe we just have to drink water. Collaborative care. We have to work with other disciplines. We have to see what's going to be best for this particular client. Implementation, we have to implement health promotion, fluid replacement, teaching patients about chronic conditions that could cause these imbalances. Acute care, we have to take care of those patients that need the replacement for fluids. For people that have ileostomies, a lot of times they have high outputs, so we are going to have to make sure that they're getting the fluid that they need to accommodate for those high outputs where their other organs are not perhaps reabsorbing the water as necessary. Restorative care. I really like even home intravenous therapy. Some people will just have to be on infusions, so they can do those at home. Nutritional support. I really like to get a dietary involved. Medication safety, medications, over-the-counter drugs, herbal preparations. We have to educate about all of these things. Nursing interventions. So interventions for electrolyte imbalances. Okay, we're going to support the prescribed medical medications or medical therapies. So oral fluids, IV fluids, electrolyte replacements, dietary supplements, anything that's going to help this patient. You might see just, water, and then you can see their supplements like Juven or ProSource to help their protein needs. IV fluids, you might see those normal salines or those D5s. Electrolyte replacements, you might see that they have to take a potassium supplement. Aim to reverse the existing acid-base imbalance. We're going to try to get them back in balance. Provide the patient with safety. Okay, that's another thing. They might be imbalanced, literally. Sometimes when these things are out of place, the patient is confused and the patient does not feel well. So we really have to provide safety precautions for patients that have imbalances. Interventions for acid-base imbalances also are arterial blood gases. These are, remember I told you that acid-base balance, which is the bicarb, is really important for those respiratory patients. Your evaluation, what difficulties are you having with measuring your eyes and nose and keeping record? What barriers are you experiencing to obtaining those potassium-rich foods you need? Maybe they just don't know what has potassium in them. Are you continuing to have frequent loose stools or diarrhea, which could definitely bring down your potassium levels? Have you purchased an antacid, or are you still using baking soda as an antacid? Any questions? Please upload them onto the discussion board. Ask the instructor. This is Miss Ebert's picture. I love her cats. Reality is the leading cause of stress among those in touch with it. So it's true. A lot of these things leave us stressed. Please don't be stressed out. Have a great day. I look forward to hearing from you. This is Nurse Bauer signing off.